My name is Michael. This presentation is about chronic pain and depression. First, I'd like to define chronic pain. According to the ICD, it is an unpleasant sensory and emotional experience associated with tissue damage. It persists for 3 months or longer and is associated with biological, psychological, and social factors. Chronic pain is also described as pain that persists longer than the expected healing time and interferes with daily functioning. The ICD classifies pain in 7 different areas, which I've listed. For example, musculoskeletal pain, which refers to pain from bones, muscles, tendons, or soft tissue. Or another example is post-surgical pain, which is persisting pain after surgery beyond the expected healing time. Now I will mention the criteria for depression, also known as major depressive disorder in the DSM. To be diagnosed with depression, a person would experience 5 or more of the symptoms I've listed on the slide for at least 2 weeks, and at least one of the symptoms need to be from the first 2, which is 1, depressed mood, or 2, loss of interest or pleasure. Also, to meet the criteria for depression, symptoms must 1, cause significant distress or interfere with daily functioning, and 2, not be a result of substance abuse or a medical condition. On a side note, some psychiatrists disagree with the measure of depression from the DSM-5, so there is some controversy around that. I will now address the risk of chronic pain and depression. There are many reasons a person can develop chronic pain. 2 examples are 1, from a traumatic event, or 2, from not receiving adequate treatment after an injury. In both cases, pain persists longer than is expected, and this leads to an increase in cell activity responsible for our sensory experience. In simple terms, the wiring of the nervous system changes, and this develops an ongoing sensitization to pain. There are also different reasons a person can have depression. One possible theory is the monoamine hypothesis, which suggests that there is underactivity of certain neurotransmitters in the body, such as serotonin and noradrenaline. Environmental factors such as a traumatic event is another reason, or a combination of biological and environmental factors. Chronic pain and depression are often experienced together, which I'll refer to as chronic pain depression. Based on the ICD, depressed mood is a criteria for certain chronic pain conditions. Studies have indicated that individuals with chronic pain are more likely to have depression. Prevalence rates do vary, particularly depending on the type of pain, but data from around the world indicate between 0.8 to 21%. There are several theories explaining this comorbidity of chronic pain and depression. One possibility is that they share similar biological structures. For example, both conditions are associated with low levels of serotonin. Another possibility is that they share similar psychological factors, such as catastrophizing or dwelling on the pain. The consensus among studies is that chronic pain and depression is bidirectional, meaning an increase in one causes an increase to the other. While chronic pain and depression seem to occur together, the reasons are mostly unknown, so it does need further research. Chronic pain and depression are persistent, which often leads to a decline in response to treatment, making it difficult to treat. Chronic pain and depression is often managed with analgesic drugs such as opioids, which may relieve pain, but there is a lot of controversy around this because of their addictive nature, and it doesn't really address the issue. Another pharmacological approach is the use of antidepressant drugs. There are several types with slightly different functions, but basically most of them address the monoamine hypothesis spoken of earlier by increasing levels of serotonin and noradrenaline in the body. Although this doesn't completely solve the issue, it does help an individual feel better and as a result more likely respond to treatment, breaking the cycle. A non-pharmacological approach which can address chronic pain and depression is CBT. This can change people's perception of pain or depression by addressing different thought patterns and behaviors. Some examples of strategies used would be cognitive reappraisal, which is changing the way we think about pain or depression; cognitive intervention, which involves changing irrational beliefs such as self-blame or catastrophizing, as mentioned previously. Pain often gets worse with lack of flexibility and weak muscles, so CBT can address any fears or motivational factors around exercise. CBT also involves education, which can include providing information about how chronic pain works, what makes it worse, the cycle of chronic pain and depression and how they feed into each other, education around specific workplaces. For example, studies show sitting for long periods of time contributes to lower back pain, which may be of interest to office workers. Treatment and prevention often coincide together. CBT strategies used to treat chronic pain and depression can also prevent them from reoccurring. For example, CBT not only reduces depression, but also enhances general well-being. Also, physical activity can be a preventative measure for developing chronic pain. There are more than 3.2 million Australians living with chronic pain, and approximately 1 in 16 Australians experience depression. This suggests that promotion of chronic pain and depression is worthwhile. I've listed some resources on the slide promoting chronic pain and depression in Australia. I would like to draw two conclusions from the research. First, to break the cycle of chronic pain and depression, more than one approach is needed. Second, typically the same approach does not work for everyone. Therefore, an individualized treatment method is needed. I would like to suggest taking a top-down approach to treating chronic pain and depression, meaning investigating and addressing general issues first, followed by specialized individual issues. A new approach I would like to propose is a 4-step process. 1. Investigate structural issues such as tumors, bulging discs, nerve irritation, etc. 2. Investigate other possible contributing factors such as medical history, work environment, mental health, or psychological stresses. 3. Create and implement a personalized plan. This might include massage therapy or acupuncture to help blood circulation, stretching for flexibility, exercise for strengthening core muscles, education and training tailored specifically to a person's workplace, such as proper lifting techniques or maintaining proper posture. Ideally, this would be coordinated by a health psychologist under the umbrella of CBT. 4. The final step would be maintenance. This might involve gradually reducing treatment sessions and introducing support groups, exercise apps, etc., and learning self-management techniques. I hope this presentation has been helpful, and here are a list of references used.